speaker that we have is going to speak on the title Examining Key Patient Safety Issues in Dental Practice and Strategies to Address Them Effectively. And he'll give brief outline from identifying safety issues, preventive measures, regulatory standards with this span of practical experiences that he has. So Dr. Tushar sir has immense experience and knowledge. He's a BDS from Bangalore, 1998. He's a master's in oral implantology from Germany. He has done certificate course in implantology from University of Miami and a postgraduate certification in quality management system. He has been an NABH accessor with the first accessor for DHSP standards, ex-faculty for NABH accessor course, and member technical committee NABH DHSP standards, KOL for various companies in implantology, recipient of Best President IDA, local branch runner-up in 2015, and recipient of Lord Powell National Award in Healthcare in 2019. He's continuously conducting various courses on aesthetics and implant dentistry under Finishing Touch Academy. And he has a wealth of experience of 25 years, and he is also the director of Chawla Dental and Implant Clinics. So, sir, we humbly invite you to start the session on the title that you are supposed to present today. So my best.
For the invitation, and it was a wonderful session going on. I was listening to Dr. Pillai just a few minutes back. And thank you for the organizers to invite me be a part of this wonderful session. I'll just share my screen and start the topic directly. I've been given the task about discussing patient safety issues in dental clinic. Well, whenever we're talking towards quality in dentistry, we all start thinking about the quality treatment which we are providing to the patient. And it is very often that we forget the paraphernalia, the background, that the structure and the processes which are required in dental clinic are also very important for patient safety. So before I start, let's understand what exactly patient safety means over here. So when we talk about patient safety, we talk about an organized framework in which activities are having, and we have a culture, we have processes, standard operating procedures, and the behavior of the staff, the engineering control, the infrastructure where technology can be used, and the whole environment of the clinic, which is consistently working towards lowering the risk towards the patients. Risk in the sense that whenever we are providing any treatment, whatever treatment we are providing, there is always an inherent chance of errors, complications, and that might impact the patient adversely. So the patient safety is actually aiming towards reducing these kinds of risks. I'll be trying to enumerate them, some of them which are common in dental clinic, and what can we do in solving these. According to WHO, 4 out of 10 patients are harmed in primary and OPD setups. Well, this data which we have is predominantly in the hospital setups and other setups. Unfortunately, if you try to see in dentistry, we don't have very strong data giving us exactly how many adverse events are happening in the clinic. If you try to search the Google and try to go through scholarly articles, and you'll find out that there is very less data available, especially in our country. Whereas in some countries, of course, we do have. But we can do understand that where our country is still at the stage of growing in quality management systems, we would be having a lot of issues in our dental clinics, near misses in our dental clinics, which would adversely affect the patient. So the main objective is to facilitate the avoidance of preventable adverse events, accidents, and complications, which are associated in providing treatment to our patients, which we can at least limit the inevitable adverse events to the patients. But whenever we're trying to do that, we have few challenges. And I mean, these challenges in hospital setup could be with the training of the staff. Of course, there was COVID-19, which was a big challenge in the near past. And luckily, we've come out of that phase. But they are still, COVID-19 was a good example in which we learned a lot about understanding that how much training we have against infection control. And we started realizing that we are not properly equipped till a great extent. And we really need to improve our technologies and things to make it better. So healthcare staff issues of training issues, issue with diagnosis of the patients. Whenever this is a healthcare setup example where patients were admitted for long-term basis, they started acquiring hospital-acquired infections and errors during surgery. Similarly, we do have adverse events happening in dental clinics. Some of these adverse events, I try to classify them a little bit so that we can understand. Some of them are medical adverse events, which could be related to medical emergencies on dental chair, like syncope, allergic reaction, cardiac arrest on the dental chair, status asthmaticus, hypoglycemia of the patient, epileptic attack, and I put extra because this list of medical complications which can happen in the dental setup are many. What we really need to do is that we normally ignore this to a great extent. I have realized, I visit a lot of clinics also, and I realize whenever I go for a procedure, as a safety checkup, before giving LA and before starting the procedure, I normally ask them once again, though we must have asked them before, that you take any anticoagulant. Many a times we've had to abandon procedures where patients were taking anticoagulant, and that physician or the doctor where I was going to do the procedure had not taken the history properly or had not instructed the patient to stop the anticoagulants as per the prescribed requirements or by the physician. So I would strongly recommend that take medical history carefully and sincerely. And it is very important, when in doubt, take physician's consent. There are a lot of changes happening on the other front also, which we are not aware of. For example, before in implants, we used to say whichever patient is using injectable bisphosphonates for osteoporosis, we cannot. It was an absolute contraindication for these patients to go for implants. Now, to a great extent, there are articles which are coming that those patients who are taking oral bisphosphonates also have to be, taken care that whether they have, how long had they taken that oral bisphosphonate, etc. I mean, there are a lot of things which we can see to it. This is just an example I'm using. Other than these medical adverse events which can happen on the dental chair, there are other events which can happen. Now, look at this picture. We have these 3 syringes. Unfortunately, a lot of our clinics do not have the habit of labeling them. Now, these syringes, if there is a saline in it, or if there is a hypochlorite in it, or an EDTA, or sometimes monomer also, we don't come to know. So this is one small thing which we can incorporate in our clinics for patient safety, that whatever we load in our syringes, because these syringes more or less look the same and the liquids are more or less look alike, we need to label them properly. And this way, many a times we can stop adverse events happening to the patient. Wrong medication, wrong dosage, or wrong injection given to the patient. There are some adverse events which are very strongly related to dental treatment. I've just tried to enumerate some of them, like wrong injection, wrong medicine, wrong dosage, accidental. This is one of the things which we don't take care, because this happens very rarely. But when it happens, it is quite, bad for the patient and even for your clinic. Accidental hypochlorite being injected through the root canal. Now, we can incorporate a lot of things. I'll be discussing that, which this cannot happen in your clinic. Ingestion of sodium hypochlorite. A lot of our clinics are not using rubber dams. I think most of the clinicians who are there would agree to me that if you start using rubber dams, there is a good chance that there would be no problems associated with hypochlorite. Also, sudden ingestion of root canal files or burrs also can be prevented from that. Patients getting injured, lacerated in lip or mucosa at different side because of sudden movement. Wrong diagnosis. This is another one big thing which keeps happening very often, but we don't realize. Wrong tooth extraction. This can also happen, which can actually permanently affect the patient. Wrong tooth is being treated. many a times the diagnosis is incorrect, and we do not do complete tests like vitality tests would really help us understand which tooth to be treated exactly. Separation of instruments in the root canal. One of the biggest problems which I found out when I used to visit various dental clinics as an NABH assessor, I used to say that I used to ask people that how do you use your endodontic instruments? And they used to give me examples, sir, I'm using this particular company and this never breaks. And I say, how do you come to know that this never breaks? Because, sir, I've used this for 7 times, 8 times, and 9 times on patients, and nothing has happened. Well, if you try to go through manufacturer's recommendation, they do not recommend you to use it so many times. And whenever we are reusing these syringes, in many countries like UK, the General Dental Council has actually banned the reusage of endodontic instruments. In fact, some of the companies which are supplying endodontic instruments over there have a small rubber in the shank that if you try to autoclave it and reuse it, the rubber is going to swell up and you won't be able to use it in your handpiece again. So this is a few things which can happen. Broken burrs in the bone, this happens. These are some x-rays which I could find from the internet where we have endodontic instrument aspirated by the patient and it's somewhere in the abdomen. Here it has been aspirated and somewhere got stuck in the trachea. And this is a burr which is taken out through laparoscopy. Later on, we try to remove the burr. Aspiration of these endodontic files and dentures as well. I had one patient a few years back who was supposed to go for a permanent bridge in the lower anterior region. And temporarily he wanted something. So I delivered a RPD at that time, a removal partial denture. And the next day he called me up and said, I feel that the RPD is slightly loose. And I told the patient that please don't wear it and please come back and show it to me. And he, because did not listen to me and he continued wearing it and didn't come back to me for a week or so. And in the house, when he suddenly popped in his BP medicine, when he popped it and he took a glass of water and he drank it, the RPD also actually got lifted and he drank the RPD along with it. And then he came to me running into the dental clinic that I think my RPDs got stuck in my throat. These things can happen. I was lucky in this particular case because he remembered, his wife remembered that I asked them not to use it, or else it could have been a problem for me as well. So taking these things a little more seriously comparatively as what normally I think the dental fraternity does is very important so that there are no such adverse events. This is also an endoscopic picture where they are trying to remove an endodontic file from inside the GI tract. These are some x-rays. The picture on your right side, you can see is of a broken burr while doing the impaction. Whenever we are trying to use these instruments, after usage, it is a good habit, and you train your staff also. Maybe you're busy doing the work. Always train your staff to actually observe the instrument because they are finally going to take out that instrument from the handpiece or something and take it for washing or sterilization or whatever. And they need to actually, raise an alarm that some part of the instrument seems to be missing or something. Like this had happened once in somebody's clinic where, the doctor did not realize while doing the impaction that the burr had fractured inside. It was later on by chance that we had seen, because we were trying to do some other procedure on that patient, that we came to know that this radiopaque substance is present inside the patient's mouth. So these things are actually which would cause a lot of discomfort to the patient. One of the small things which we should start following is trying to, tie floss to your endodontic instruments. If you notice, all the endodontic instruments have a small hole at the handle. And I have observed in my span of assessments which I did, I started assessments for NABH somewhere in 2008 when NABH was not launched. And then NABH was launched in 2010. That was the first standard. I think most of you must have not seen that standard. The second edition had come in 2012, where there was a assessor course conducted in which a lot of people like Dr. Charubala was a part of that team. And that is when 32 assessors were made. And then henceforward, I think there are a good number of assessors in the country now who are doing NABH. But most of you must have observed, we rarely find these floss tied to these endodontic instruments. Sodium hypochlorite accidents can happen, small spillage on the clothes, accident spillages in the eye, and allergic reactions. Also, air emphysema. A lot of people, if you've noticed, use air, three-way syringe inside the root canals to actually dry them up. So this is a big problem. And to recognize that these patients, the moment you have injected hypochlorite, would actually complain of immediate pain or burning sensation in that particular area, what are you supposed to do? We need to create standard operating procedures in our dental clinic to actually, dilute that particular area. So if you try to go through the standard operating procedures of various organizations who have actually formed, I think I'll cover that in the next slide. It is there. Even injuries to the eye can happen. We all of us, when we used to go for assessments, used to ask the organization to have these eye wash containers. With these containers, you can wash your eyes more easily. And of course, prevention is always better than cure. You can actually give all your patients an eye protective gear before you start the procedure. This will actually prevent a lot of adverse events happening on the patient. And of course, in the end, refer your patient to the ophthalmologist. This has happened with me myself, not just hypochlorite. I was doing bleaching for a patient, and I know most of you might be clinicians over here. I was using Polar Office. Polar Office, the hydrogen peroxide comes in a syringe form, and they have a small bottle, powder bottle, and you're supposed to inject that syringe inside that container, mix it, and then start using it. All these syringes which are packed, they all have a small air bubble in the starting, because they are supposed to be packed like that. That way, that's sort of an air seal where they cannot get contaminated. So whenever you open that, if there is no syringe or a needle placed in front of it, there is a good chance that this hydrogen peroxide would suddenly come. And we need to be really careful. It has happened with me, my own self, that hydrogen peroxide fell into my eye and I had to wash it. Luckily, no permanent damage had happened. It was just a temporary thing. So one of the things we have to remember, that cases where we have wide apical foramina, where apical constriction has been destroyed during excessive root canal treatment, or extreme pressure is being used while irrigation, there is a good chance of these hypochlorite accidents. Also, whenever we use this, we have to ensure that the binding of the irrigation syringe, the needle to the syringe, is better. And to prevent, it is always recommended that we start using with lure lock syringes so that such problems do not occur. So these are patient safety issues which we have to keep in our mind. We need to, while procuring our products, we need to take care. And many a times I've seen over the years, a lot of people start feeling more confident about their root canal, and they do not initially determine the working length X-ray, or don't take a check on it, or don't use a apex locator. And many times they end up actually going beyond the apex, and henceforth even the sodium hypochlorite sometimes. This is a picture which I've taken it from internet, where you can have hematoma, ecchymosis like this in the skin and mucosa because of sodium hypochlorite being injected periapically. And it can travel into different spaces. This hematoma can travel into different spaces and cause a lot of pain and anxiety to the patient, which is not good for you as well. The edema sometimes causes swelling of the eyes, and it almost closes the eyes. And this is an intraoral picture of what may happen if you inject hypochlorite through the canal. You can see there is necrosis of the tissue in that particular area and perforation of the tissue where the bone is exposed. These things can happen. Luckily, most of us in our practices might have not seen, but these are the things, because we have other people also employed in your clinic. The organizations which are focusing towards accreditation, or even if they're not focusing towards accreditation, are focusing towards providing quality care to our patients, need to keep these things in check, need to consider these things, that these things can happen. They have been reported many times over the globe. Supposing it happens, what is supposed to be done is another big question which is asked. First thing we need to do is give a local aesthetic in that particular area. By giving a local aesthetic in that particular area, first of all, we would be causing vasoconstriction of the vessels over there, where you will not have a spread of that injected hypochlorite in a larger area. You would prevent that spread. The pain of the patient would be actually managed properly. And the second thing we need to do is irrigate that area with the saline through the same canal repeatedly so that we are able to dilute the hypochlorite and reduce the harmful effects of the hypochlorite on the patient. And of course, after that, we can do cold compressions, put the patient on antihistaminic and corticosteroids. Prevention, of course, is always better. So for prevention, I would strongly recommend that all of us ensure, and as assessors who go to the clinics to assessments, ensure that we have syringes which has a side vent and have a lower lock so that such things do not happen. Other than these medical and dental adverse events, in your dental clinic, you can have other adverse events which are not related directly to the treatment. Like, for example, I remember my clinic has a small step when you enter inside the waiting hall. And one of my assistants came and told me that sometimes when the patient steps on that particular doormat, the doormat slips. And one of the patient almost was about to fall where they controlled themselves. So this was a potential hazard. So by bringing a culture of safety in our dental clinic, we change that mat, right? So these are the things which we need to see. Fall of patients. And Dr. Vishwas would actually say, I remember once having a full discussion with Dr. Vishwas about vicarious liability. Even if the patient falls in the waiting hall inside your organization, you would have a vicarious liability, and medically the patient can actually go against you. Of course, there would be natural disasters, and your clinic should be equipped to manage disasters like that, where there is an earthquake or if there is a fire, or there could be assault from external, from patients as well, electric shock also. All these things we should keep in mind. Other than that, one of the most important things which I see is missing in many of our dental clinics in India is radiation safety. Though AERB is working very hard and is trying to do a lot of things, we forget the principle of alarm, that is, as low as possible radiation to the patient. Many of times I see my colleagues taking repeated working length x-rays because they're not using proper aiming device, they're not standardizing these x-rays, and henceforth they're not having a complete view in one of the x-rays. And of course, using lead apron and thyroid collars in our dental clinic. I hope I'm not crossing the time. If anybody could just give me an alarm when I come to know that I'm not crossing. Anyways, this is a small classification which I found out from the internet through an article where they're talking about dental adverse events severity tree, where you can actually see that they have categorized into temporary minimal harm to patient's death on dental chair. Very recently, there was a news of death on a dental chair of a patient in a particular state in our country, where we try to understand actually what had happened. But it is sometimes some things are inevitable, though a lot of precautions were taken and the clinics seem to be very well equipped to manage all the emergencies. But these things do happen. And one of the major reasons why it happens is that we do not have proper procedures, standard operating procedures in our clinic. And that is why the hazard finds the holes between all our processes and organization, the technology we have implemented, and losses do happen to the patient. One of the major reasons is our ignorance, our ineptitude, and necessary fallibility of what can happen, because science and technology is still to be understood by a man completely. And there are few things which we cannot completely understand, but if we have a culture of minimizing the adverse events, it would be wonderful. How can we actually implement this culture is by doing mock drills, multiple mock drills of potential hazards which can happen in our clinic, and train our staff repeatedly. The dental team should be on the alert of the possibilities of adverse events which can happen, and they should be empowered to speak up whenever they identify such things. Because adverse events cannot be completely eliminated, the team must be trained in recognizing and management of the crisis. How can we train them for management of the crisis is through mock drills. This is one article which was there, which was saying that these mock drills need to be done again and again, because there was, in this article, they tried to study 133 subjects who were trained, and they were taken test after 3 months and 12 months. And they realized that half of the things the subjects have forgotten of what they have been taught. So the repetition of these mock drills are very important. We need to ensure that they develop the ability to put the acquired knowledge and skill to work whenever it is required. Because whenever they are in pressure, that is, whenever something of this sort happens in our clinic, our colleagues, our doctors who are working with us, the staff which are working with us may go under anxiety. And as a result, their cognitive skills, their behavioral skills, all might change. And the pressure camouflages the real knowledge which a person has. So mock drills are very essential, though we can use simulators, but that becomes very expensive. So in these mock drills, we need to ensure whenever we conduct these mock drills that what is happening is monitored properly. All the roles and responsibilities are actually distributed among the staff. And within this mock drill, there should be one person constantly monitoring the mock drill so that you can improve and find out that what works good for your own setup. In the end, I would like to mention that Stopar should be the way of going about things. They should understand this concept that the first thing what they need to is they should control their anxiety, stop their fears, think, get organized, observe what has happened, and see how you can actually prevent it and act accordingly. Very important is that they all work as a team together instead of going haywire. So if you keep conducting mock drills, the probabilities of having such adverse events would be very less, and the patient safety in your dental clinic would be far more than any other dental setup. I
So
think
we are running out of time. So if you
I'm
can
done.
just
This is my
okay.
last slide. So you were
All
on.
right.
I think I'm on time that way. So in the end, I would just say bring culture of patient safety in your dental health care provided setups. Thank you.
Thank you so much, sir. And it was really a pleasure listening to you. You had shared all the experience, and it was an engaging audience that we had because they were lot to experience, lot to see, and lot to learn from it. So once